And now it is my pleasure to introduce today's speaker, Shelley Fulton-Nassau, CEO of NCCS. Shelley, welcome to the program. Please begin.
Thank you, Crystal, and thank you to everyone for joining us today. We are lucky to have two great speakers who can share the perspective from two different states or jurisdictions that have implemented the Affordable Care Act and with different environments and different challenges that they've faced. We wanted to host this webinar because we know that with all of the efforts to repeal the Affordable Care Act this year, there's a lot of confusion among the population about what's going on. Some people think it's already been repealed, and the Trump administration has shortened the open enrollment period so that it's only 6 weeks instead of 3 months, and also cut funding for outreach and assistance. So we wanted to make sure that we arm our advocates and anyone who can help get the word out about enrollment with information that they need to share with their constituents and to be able to help people enroll. So we are turning to two incredible experts to help us with that. But before we turn it over to Jodi and Debbie, I'm going to ask Lindsay House, NCCS Public Policy Manager, to give a brief update on the ACA from a legislative perspective.
Thanks, Shelley. Hi, everybody. I just wanted to take a couple minutes to set the stage for what's going on at the federal level with ACA and the politics sort of surrounding it this year. So NCCS has really been working all year to ensure that the ACA and the patient protections that are included in the law remain in place. And it's been quite a roller coaster. It feels like there's been an effort to repeal the law every month or so. And I like this image here of the dog that caught the car because I kind of think, this is where Republicans in Congress kind of are right now. Since the ACA passed in 2010, the Republican members of Congress have railed against the law and have attempted several times to repeal it, but now that they're in the majority with majority in the House and the Senate and in the White House, it turns out that, as President Trump said, healthcare is very complicated. And so this analogy of the dog that caught the car and thinking, okay, now what, is a lot like the healthcare debate right now. And I think it was Senator Manchin from West Virginia earlier this year had a quote that I think also captures the debate quite well. He said, people might not know who gave them these benefits and protections, but they're surely going to know who took them away. And so I'm just going to go over a quick overview of the ACA roller coaster this year. So in March, the House released a repeal and replace bill called the American Healthcare Act, or ACA. And ACA would have eliminated the Medicaid expansion, it would have drastically cut traditional Medicaid, and it would have allowed states to charge older Americans higher for their health care, and it would have gutted the ACA's patient protections. And so it failed to get enough votes in March, and so Speaker Ryan pulled the bill, and it never made it to the floor. So then in May, the House Freedom Caucus, which is the right-wing caucus of the Republican Party, revised the AHCA and added an amendment that actually made it more harmful to patients. And this version actually passed in the House, and it would have eliminated community rating, so insurers could charge individuals with pre-existing conditions more for their coverage. And the Congressional Budget Office estimated that about 24 million people would lose insurance under this bill. So once the House passed this version of ACA, then the Senate created their own version, and they called that the Better Healthcare Reconciliation Act, or BCRA. And the Senate bill would have resulted in 22 million losing coverage, and it also would have gutted protections for people with pre-existing conditions, and it would have raised premiums and destabilized the market. So the Senate voted on BCRA and then two other Senate repeal options back in July, and thankfully all of them failed to pass that night, and that was when McCain had his dramatic late-night thumbs-down vote for these bills. And so we were pleased to see that they were stopped, but then, of course, going back to the roller coaster of a year with repeal-replace efforts, as soon as Congress came back from August recess in September, Senators Graham and Cassidy released their bill and pushed it through, in this bill, the Graham-Cassidy would have block granted the ACA funding to the states, and it would have allowed states to gut patient protections, and it would have dismantled the ACA and the Medicaid expansion. And so thankfully, they were not able to get enough votes for this version of repeal as well. And so it's been quite an interesting year with all of these efforts to repeal the law, but thankfully the ACA is still the law of the land. And actually, since the summer, there's been a bipartisan effort from two members in the Senate, Senator Alexander and Senator Murray, to develop a stabilization bill. And every time a new repeal effort has come up, that has sort of taken a back seat. But they're still working on that bill, and we're hoping that that will get passed by the end of the year. And that bill would it would ensure payments, the CSR payments, cost-sharing reduction payments, that help low-income Americans afford their insurance premiums. As Shelley said earlier, the administration has taken steps to undermine the ACA, and one of those steps has been the executive, or I guess it was an executive order. The administration said that they would not fund the cost-sharing reduction payments. They also cut ACA's advertising, assistance, and outreach funding, and they cut the length of open enrollment in half. And so, we're glad that ACA is still the law of the land, but we've heard from the Republican senators that they are planning to bring up the Graham-Cassidy bill again in early 2018, and so we need to remain vigilant and make sure that the ACA and the protections that it provides for cancer survivors remains in place. And so now I'm going to turn it over to Jodi here to talk about navigating healthcare coverage and some of the changes that we can expect to see in this year's enrollment.
Thanks. The first question most people have is, why did we need the healthcare law in the first place? And the answer is that we had a health insurance market that worked very well for big insurance companies, but not so well for American families. Insurers could pick and choose who they gave coverage to, and premiums were skyrocketing, even as insurers made record profits. As a result, tens of millions were stuck with coverage that didn't cover critical treatments and preventive care, and many of those who had insurance didn't understand the basics of their plan and were afraid of losing it if their employer dropped coverage or they switched jobs or retired. 50 million Americans had no insurance at all. This left many Americans feeling like their health care choices were out of their hands. The market was especially broken for small business owners. Many couldn't afford to provide coverage for their employees, and those who did paid more and knew their premiums could skyrocket if one employee got sick. For many business owners, this meant choosing between keeping their employees covered while rates kept rising and profit margins kept shrinking, or foregoing coverage at the risk of losing good employees. That's why Congress passed and the President signed the Affordable Care Act. So under the ACA, we know that millions of people who were previously uninsured or underinsured, particularly when you look at a state like Florida, but across the United States, are now eligible to obtain and enroll in quality health insurance coverage. We know that health insurance is complex, and as we listen to the coverage on the news all the time, we know it's getting more and more confusing. It can be difficult to understand, trying to explain the differences between coinsurance and copayments in and of itself is complex and confusing. And therefore, people more than ever are needing one-on-one assistance in order to determine what their coverage options are. In states like Florida that didn't expand Medicaid, we have still remaining enormous coverage gaps. And an example of what these coverage gaps look like, I use this for Florida. This is what it looks like. There's a whole hole in what is coverage, what coverage is available, that there are no options for those individuals. So those states that didn't expand Medicaid, we continue to leave hundreds of thousands of individuals without coverage. Under the ACA, there were some elements that were really important and common for all states. Asset tests, disregards, interviews, non-magi methods, separate application, etc. are still in place currently under the they're eliminated, under the Affordable Care Act, and although are still permitted for seniors and disability-related eligibility terminations. We've come a long way with children's coverage. We know that we've created opportunities for presumptive eligibility, 12-month continuous eligibility, eliminated the interview requirement, the asset test, and where possible, trying to utilize administrative verification of income, reducing, of course, the amount of documentation that people have had to submit to verify their income or their status so that they can get and obtain coverage. We've done much better with the parent coverage, too. In the past, particularly, again, in states that didn't expand Medicaid, but there were some states that did utilize some of their CHIP dollars to provide coverage. Many states did not do that. We've eliminated, there are no more interview requirements, again, under the ACA, no asset tests, Social Security data matching, administrative verification of income, simplified renewal, and 12-month eligibility. Now, of course, we just need to find a way to fold in the remaining parents and expand coverage to childless adults who cannot enroll into the marketplace. The other way, I think I went too far. The other key element of the Affordable Care Act, of course, is creating the no wrong door and creating multiple modes for enrollment. Now, individuals do not have to apply to the marketplace, to Medicaid, to CHIP separately to get everybody in the household covered. Now, all these programs work together. They share information. They're utilizing the same modified adjusted gross income approach to verifying income and verifying other eligibility status and citizenship, which simplifies the process for individuals and for their families. They also have the ability to apply over the phone, online, in person, depending on what is easier for the consumers. And again, better coordination of these coverage programs because they're sharing the information. So even if an individual applies through the marketplace, maybe a child will be eligible for Medicaid or CHIP, they're sending that information out to the states. And depending on the states, that looks a little different. In some cases, some states will allow the marketplace to determine eligibility. For states like Florida, the marketplace really assesses eligibility and then makes a recommendation and a referral to Medicaid or CHIP. I think some other really important elements of the Affordable Care Act are that we have not only no more additional out-of-pocket costs for preventive care, for well women visits, for screenings and other things like that. Women are no longer being charged more for being women. We can keep the young adults on coverage up to 26. Obviously strengthen the Medicare program. And we also know that insurers no longer, they have a cap on what they can use for administrative costs, and the rest of the costs have to be applied towards providing health care. Some other elements of the Affordable Care Act that is making health insurance more affordable. With the preventive care, we know that getting preventive care like cancer screenings and vaccines is one of the best ways to stay healthy. In the past, too many Americans went without this care because their insurer didn't cover it or required expensive copays. When the choice was $50 for a mammogram or $50 for groceries, many women had to take their chances. Now they don't have to do that and take that risk any longer. Thanks to the healthcare law, a wide range of recommended preventive services are available for free in all new plans. We know that millions of Americans, since the Affordable Care Act has been implemented, have gotten at least one free preventive services through their private health insurance plans. Additionally, the Affordable Care Act provides for the establishment of the essential health benefits. Packages that generally cover essential health benefits include some of these listed here, like ambulatory services, emergency services, maternity care, and some of these were prior to the Affordable Care Act, may or may not have been included in some of the covered benefits that the insurance plans were providing to consumers. So I think it's important to know that all plans are required to have, at a minimum, these benefits as part of their plans. The marketplace also was established. In some states, there's a state-based marketplace that is run by the state. A lot of states decided not to create their own marketplace, and they are participating in the federal marketplace. And then we had some state partnership marketplaces in a handful of states that were a partnership between the federal and state governments. All of the states and all the marketplaces not only provide an opportunity to go shop for health insurance, when they shop for health insurance through the marketplace, consumers can also apply for other kinds of discounts and subsidies that are available to them based on their federal poverty level, their income level. So from 100% to 400%, individuals can qualify for income tax credits that will bring down their premiums. So those individuals that qualify for tax credits will see themselves qualifying for lower premiums than those who are going to be paying full pay out of pocket with no tax credits. And there's a huge difference depending on the income level of the individual applying. In addition, from 100% to 250%, individuals get the cost-sharing subsidies. And as that was referred to earlier, there's been a lot of coverage around that because the administration said they were no longer going to pay those cost-sharing subsidies out to the insurance companies. Unfortunately, for the insurance companies, they're still required to honor those for the consumers. So consumers are still qualifying for the cost-sharing subsidies. And we are still seeing most of our consumers coming in, and they are able to get those tax credits and cost-sharing subsidies. I think it's also important to know that there are 4 different levels of health insurance plans, and depending on whether the individual is getting both tax credits and cost-sharing will depend on which of these middle tiers might end up being providing some of the best coverage options. Obviously, if they're 100% to 250% and they get to qualify for the cost-sharing subsidies, those are only available through the silver plans, the silver level plans. Those are where you see the cost-sharing subsidies kicking in and bringing down some of the other out-of-pocket costs like the deductibles and the co-pays. The tax credits will bring down the premium, so consumers can very well get a very inexpensive, very comprehensive plan through a silver level plan. We have seen those that maybe didn't get cost-sharing subsidies but are still getting tax credits. We've seen some individuals who are getting even less expensive plans at a gold level. So we're seeing consumers get some pretty interesting options for coverage during this open enrollment period so far. And each of these levels, as you can see, relates to how much of the insurance plan pays out. So with the bronze level plan, it basically covers 60% of the costs, the medical costs. Silver, it'll be a 70-30, 30 being on the part of the consumer, gold 80-20, and then platinum 90-10. However, with cost-sharing subsidies and tax credits, a silver plan could end up looking more like a platinum plan, and that's not unusual. Some other basic eligibility requirements: you must be a U.S. citizen, you must be or a legal resident, cannot be incarcerated. That's a question on the application. I think it's also important to remember that the law is still the law, and with the law is a mandate. So not only are all of these discounts still available and people are still able to benefit from them, but the mandate is still a requirement, and without health insurance, many people will end up paying a penalty if they do not have coverage through a qualified health plan that meets the essential benefits package. So I think it's a good idea to be aware of what the tax penalties are. I mean, for an adult, $695; for a child, $347.50, or it could be 2.5% of the taxable income above the filing threshold. So I think it's important to recognize that an individual may not enroll in a plan, but they're still going to pay the penalty, and any out-of-pocket costs at no discount for any medical care. So they're going to pay out-of-pocket, could be a substantial amount of money throughout the year depending on their circumstances, and they will have no coverage. They will have nothing to show for that. So I try to remind people and show them, comparatively speaking, depending on the cost of the plan, you could really pay a whole lot less for insurance coverage than you would for the penalty. There are some exemptions to the mandate. If the coverage, there is no affordable coverage. A member of a health sharing ministry, obviously a recognized tribe, are eligible for services through the Indian Health Care Services, a recognized health sect, and also in some states, particularly those in expand Medicaid, those individuals below 100% won't get tax credits because 100% to 250%, or the 400% do get tax credits for the marketplace, but under 100% they do not qualify for tax credits, because the idea of the Affordable Care Act was those individuals would have the ability to roll in Medicaid. Obviously, with the states having the option on whether to expand Medicaid or not, that ability to roll into Medicaid for a lot of childless adults who make less than 100% of the federal poverty level is not an eligible option. I think the other thing to remember, though, is that states did not have the option not to expand Medicaid for children. So there was Medicaid expansion for kids till they turned 19 in all states. That was a requirement. That was not optional. But I would say that we know, based on the trends from the last 4 years of open enrollment, the effects have been startling. We know that millions of folks have been able to enroll into coverage, and it's not just the marketplace. They've gotten into coverage. We've seen increases in Medicaid and CHIP, even in those states that didn't expand Medicaid. We have seen at least some reductions in the healthcare disparities, particularly among some healthcare conditions such as diabetes, asthma, certain cancers. We know that more people are seeking out preventive services to address how some of these more chronic conditions are cared for. That certainly does reduce healthcare costs as well, because they're not any longer seeking care for things that are more expensive once they're accessing that care. And so we know that the law is working. We know that, as we've seen in a state like Florida, for example, last year we had 1.7 million people sign up for coverage. Every year we have seen a growth in the number of people that have enrolled in the marketplace. And as I said, in states with Medicaid expansion, certainly the increases in enrollment have been startling. These are some other individual mandate exceptions, obviously, that I've already mentioned. And then just to talk a moment before I close, we have navigators all over the country. Our navigators cover in Florida, Pensacola to Key West, and we are holding Nav Labs, navigator events, enrollment events. We are out there trying to, as was mentioned, Navigator grants were cut. Ours was cut by a significant amount. So we are working very hard to engage other partners. We've gotten some athletes to help us with some PSAs. We're doing whatever we can to get the word out. We're seeing some real challenges getting the word out into rural areas across the country. That is beginning to be a lot more difficult with the minimal resources that everybody's working off of, and we need more help with that. But, you know, we have people on the ground. They're mobile. They're working in communities. They're going out to areas where transportation is an issue. In addition, they are helping people understand their options with CHIP and Medicaid, and Navigators are really able to help them know which application really is the most direct door so that consumers don't have to guess on their own. So programs like Medicaid or Healthy Kids, which is our CHIP program, and the Marketplace, while they all have different applications, we want families to take the most direct route into coverage for the members of their families. And that's what Navigators are out there doing, and they're on the ground trying to get the word out. A couple of other things to note. These are the key enrollment dates. This is really important. Obviously, enrollment ends December 15th. People are going to lose their coverage for 2017, December 31st. If they have not picked a plan by December 15th and enrolled, they will not have coverage for January 1st. So please, please encourage people to get out and get a chance to review their plans, make sure they know what plans. Some of these auto-renewal plans may not be the plan that consumers need. We found consumers are getting auto-enrolled into plans that don't have their providers on them. So reviewing plans is important, really important. And I'm really concerned that people are going to be caught off guard by the shortened open enrollment period. So all that we can do to drive people to those sisters and let them know will be valuable. Thanks.
Thank you so much, Jodi. That was great. Now we have Debbie Curtis, who's the Deputy Director for Policy and Exchange Programs at the DC Health Link. Debbie?
Yep, I'm here. Thank you guys for inviting me to do this call with you all today, and thank you to every single person who's on the phone and wanting to know what you can do to help, because we need help. We need help everywhere across the country. And I also want to say that having Jodi on to talk about Florida and then having me from D.C. is a really good overview of the country, because we have two very different stories to tell. So in the District of Columbia, D.C. was one of the first states. I'm going to call us a state. That's what we think we are, and we should be, and we should have representation, but that's a different tirade. So we were established pursuant to once the Affordable Care Act passed. The district decided two things. One, the district was going to expand Medicaid immediately, and the district, unlike Florida, which chose not to expand Medicaid, the district actually expanded as far as we could get away with. So for childless adults in the District of Columbia, Medicaid goes to 215% of poverty. So we have a huge Medicaid program in the District of Columbia. We also decided to build a state-based marketplace, and the reason that the district chose to develop a state-based marketplace is that they really wanted to be able to develop a market that was built from the ground up with the residents and the stakeholders in the district making decisions about what works for them. And these two decisions turned out to be so prescient given the outcome of this last election. So in D.C., our health insurance marketplace does not have tobacco rating, which is something that the federal marketplace has. We did that because we want people to stop smoking, and it's free preventive coverage, and you're not going to get people into treatment if they're having to pay a huge fortune for their premiums. We also don't allow substitution of benefits by the health plans. They have to cover everything that's in our essential health benefit package, and we have a really strong standard plan system that lets people compare apples to apples, and that makes sure something exciting we were able to do last year in our standard plans is that we've excluded excluded from the deductible your specialist visits, your primary care visits, and mental health visits, so that you really can get the services you need, even if you're in a higher deductible health plan. So DC HealthLink went into operation October 1, 2013. We were, as reported by Bloomberg News, one of only 4 state marketplaces, and including the federal marketplace, that stayed open all day on that day, and we've been open ever since. We also made another decision in the district because we're small. We said we don't want to have 2 sets of rules for on-exchange, off-exchange. So in DC, everybody who buys individual health insurance comes through DC HealthLink to do so, and everybody who buys small group health insurance, so all small businesses up to 50 employees, buy coverage through DC HealthLink. We're covering an average of about 17,000 people in our individual marketplace, and we have more than 76,000 people covered through our shop marketplace, and that actually includes members of Congress and their staffs, which is another aside from the Affordable Care Act, but we're providing them very strong coverage. Then the other thing that's important is, since the Trump administration has come in, we've seen them take steps, and Jodi referenced several of these. So, for example, the federal government decided to shorten this year open enrollment to a 6-week period. Because we're a state-based marketplace, we could make the decision that that did not work for us and was not a benefit to our residents. And so we have maintained the full 3-month open enrollment period that we had last year. The Trump administration also did regulations to make special enrollments more difficult. You have to provide a lot more documentation and verification. We chose not to do that. In the District of Columbia, our enrollment is very young, and if you put barriers to people being able to get covered, they're not going to get covered. So we were able to make the argument that actually hurts our risk pool, and we were able to keep our process working the way it is. They chose, as Jodi already mentioned, to gut Navigator funding. We have maintained our commitment. We fund our organizations here through through DC HealthLink, and we've maintained that commitment, and we're working even harder for free media. And on outreach, that's true as well. We are increasing our investment in outreach. We used to benefit tremendously from the federal advertising, especially because we're located in DC. We had a huge boon from all of that advertising. That's gone now. And we also know that through our analysis, about 50% of our customers actually get to us by first going to healthcare.gov. So, this change at the federal level is, even though we're far better off than a state like Florida that didn't decide to create a state-based marketplace or expand Medicaid, we're still being negatively impacted by what's happening at the federal level. So what we're doing to emphasize that we're here, we're open, we're going strong, and we want you to be covered, is that we have really upped our efforts on getting free media and it's called earned media, it's not free. But we had, for the first time ever, we did a big press conference with our mayor. That's the clip that's on the screen that you can see. She has become incredibly active this year and did both this event on November 1st to ring open DC HealthLink for Business, and we did a whole festival downtown in DC on Saturday that she also joined us at with all of our community partners, and really just getting the word out on the street that we're open for business. The other interesting thing we're doing in D.C., and again, because we're a state-based marketplace and we're trying to make sure that we can continue to build on what we've done with the ACA in D.C., since we opened for business, we've cut the uninsured rate in D.C. in half. We rate between first and third in the nation, depending upon the study that you look at. And our attitude is we have about 96% coverage, and we're not done until we're at 100%. And we don't care if the federal government changed. We care deeply that the federal government changed, but we are going to keep working to expand on this. So we actually developed a working group this summer to take a look at the steps that were happening at the federal level and what do we need to do in the district if we want to protect what we've started here. And so this work group just finished its work this last week, and it's going before our executive board this evening. And this diverse group of stakeholders that included our 2 health plans in the individual market, included brokers, small business representatives, consumer advocates, an AARP representative, hospitals, it really ran the gamut of everybody. They all came out together saying that we should move ahead in D.C. with a local reinsurance program to help keep our premiums affordable, that we should invest in actually a RAP subsidy program around APTC, so the tax credits that Jodi was talking about that increase affordability, they do increase affordability, but not enough. I mean, we continue to hear from our navigators and assisters here in the district that when people don't enroll, they don't enroll because it's not affordable for them, even with that coverage, even when they qualify for financial help. So we want to use local dollars and increase that financial help so that premiums are really much, much more affordable for people who are coming, whose incomes are just over Medicaid eligibility. That difference between being a Medicaid recipient and having to buy private insurance is huge. The cost differential is thousands of dollars, and these are not people who have thousands of dollars lying around. So we are trying to move forward with that initiative. Our board will vote on it tonight. It will go to our mayor and to the council. And if we're able to get this enacted, this package will be, I think, the most comprehensive response to date from any state of how we're moving ahead to continue to build on the ACA, as opposed to have it be torn down from the federal level. And I would note, on a totally just a political statement, but given that it was yesterday, I think it's fair to say, the exit polling that's coming out of the elections that took place yesterday indicate in Virginia, healthcare was the #1 voting item for people. Having spent 30 years in public policy working on healthcare, that's never been the case, and that really could drive some change in the next year at the federal level with regard to how much more they want to continue to mess with the Affordable Care Act. So I take some real positive perspectives from that. Let me also say that for you all wanting to get involved in help, thank you, thank you, thank you. Number one, you need to be telling everybody you know and spreading through social media that the Affordable Care Act is the law of the land. Open enrollment is now. Our line is don't delay, enroll today, and get people covered. If you are in a state that has a state-based marketplace, I strongly encourage you to reach out to the leadership of the state-based marketplace. They will want your help. They will find ways to plug you in. They will share information with you because everyone's trying to do greater outreach now. If you're in a federal marketplace state, there are still navigators, as Jodi being on the call shows you. They're hugely underfunded, but they are still there. I actually reached out to CMS to see if I could get a list of all the navigators that still exist by state. And, this will come as a shock to some of you. They haven't quite updated that on their website yet. But they did send me the link, and I'll send it to Shelley. They're going to be soon. They will be updating it. What they have up there now are the greater number of navigators that existed prior to the 60% cut in funding that they put into place. So I will get that information to Shelley so that she can share it, and hopefully at some point it will be updated and be more accurate. But amplifying this message that we're here to serve, get covered now, the law is still here, and many of us want to see it stay here forever. And I would note, maybe Shelley sending out the link of former President Obama, actually, on November 1st, did put out his own message about the Affordable Care Act. So it was nice to see presidential leadership. I would like to see it in the current administration as well, but we take what we can get. And with that, I'll be quiet so we can have a question and answer time.
Great. Thank you so much, Jodi and Debbie. Debbie, I'm glad you went there. I was going to ask you about the election, but you did it anyway. But what about, can you also address, I'm just going to start with the questions. If you have questions, use the chat box to enter them. But we have some questions here that we want to ask both of you all. What about, can you talk a little bit about what happened in Maine with Medicaid expansion, and what is that, I think that's another example of where health was really important in the elections yesterday.
Yes, it is. That's another great one. I should have mentioned that. So in Maine, they chose not to expand the Medicaid program. They have a governor who's rather outspoken on all kinds of things and has very strong opinions that he doesn't like to change. Their legislature has tried 5 times to force through a Medicaid expansion in the state of Maine. They've been unable to get it because of the governor, and so they took it to a ballot initiative, and it won last night. And so, again, at the very time that at the federal level we see consistent attacks happening on the Affordable Care Act, you saw in Virginia and in Maine very strong reactions from voters saying, no, we want to go the opposite direction. And I would say, and Lindsay did the overview at the beginning at the federal level, I would also note that one of the outcomes that we really, I think is an outcome of the federal efforts to undermine the Affordable Care Act was that it actually strengthened the Medicaid program and the Medicaid program's reputation nationally. I was stunned by the number of Republicans speaking out against the Medicaid cuts when in the past that has been something they've been very comfortable doing. And it's the expansion of the ACA that absolutely helped make that be the case, because so many people gained coverage under Medicaid and would lose it under the initiatives that were before Congress this year. And make no mistake about it, if something happens to undermine the Medicaid expansion, where states are going to have to go is helping figure out how to get those people covered. That's going to be priority number one, because those are poor people and children who have no other way to be covered. And the risk of that is that the gains that have come through the Affordable Care Act for people who are above Medicaid eligibility, I mean, they're going to be dropped like a hot potato by states. I mean, the states don't have the resources to do all of this on their own, and they're going to have to, triage and focus where the most help is needed. And so, cuts in Medicaid will just be devastating to health coverage in the United States if they were to happen.
Okay, so here's another question I want to ask you both to help us with, and you've both touched on it, but I think what's so confusing about this year's open enrollment is people hear the message that premiums are sky high, but I don't think they're necessarily hearing the message that subsidies are also higher, and that it is possible to find affordable plans, and that because of the way a lot of the uncertainty about cost-sharing reductions was loaded into the silver plans, the surprising result is that you could do better with a gold plan. So it's really, really important to shop for it. But I guess I'm wondering, both Jodi and Debbie, do people understand any of this? My worry is there are really great options out there, but people don't know it because they only hear sky high premiums. And how do we break through that and help people understand that there are really good options, and you really have to shop? You can't just go with what you had this last year or this year, because you may get a better deal on a different kind of plan. But you have to know how to navigate that. So how can we help get that message out?
That is a vital message to get out. We constantly are as shop, compare, enroll. Shop, compare, enroll. We, and again, a benefit of being a state-based marketplace, we have a special email tool that we can communicate with our customers. We can tell when they open them. We can learn what messages work. We just did, over 17,000 auto renewals for people, meaning, you don't require people to renew their coverage. You automatically renew them. You send them a notice saying you've been auto-enrolled, this is your plan. But we say in there, but you should shop and compare. You may have a better deal in a different plan. Every year the plans change. And so we will continually send email notices and reminders to our enrollees, encouraging them to shop. We've already seen in the 1 week that we've been open that our shopping rate is higher for auto renewals than it has been in the past. So we'll see if that continues. But that, we all have to get that message out. You're absolutely right. The premiums are going up. In some states, they've gone up astronomically. But, averages are just that. They're averages. And so there are some plans that didn't go up and that you can get a better deal on. And if you qualify for financial help, 100% the increases aren't going to hit you. And in fact, the weirdness of all of this is a lot of people who qualify for APTC are seeing cheaper premiums this year because in the states where they had the problem with the CSR payments, they've loaded it all onto the silver plans, and that means your tax credit is huge, and so your premium ends up being cheaper. And the federal government, by the way, is spending a lot more money this year on these tax credits because of this ridiculous policy at the federal level. I mean, this was, stated that it was done to save money, and in fact, the federal government will spend millions more on the tax credits this year because of this change.
I think the message that we want to keep getting through is that and quite honestly, we say this every year, but I understand why this year is slightly different in that we always want people to review their plans. I mean, with auto renewal, that's great if you get to keep your plan and you're happy with it, and they got these letters that told them. But one of the things that the consumers need to make sure is that, if they're keeping a plan that they have, maybe contacting their providers and making sure their providers are still on those plans and are still accepting those plans. So that's one thing that's important. But the other thing is some of these, I know, for example, Humana pulled out of our market, and so people were auto-renewed into plans. And we've seen some people get auto-renewed into plans that didn't have any of their providers, and those are individuals who might represent high-end users of healthcare. So that's really an important feature of a plan selection. And so sitting down with somebody to sort of sort through the plans that will provide coverage for the providers that they need to be able to see, as well as not just coverage for the individual providers, but for the services, is always really important for consumers. So we really tell people to take the time to do that, even if they have a plan they like, just to make sure it still works for them.
We have a question from a webinar attendee named Mindy, and she says, I write for an audience of people who have cancer. Is there special advice you would have for them?
This is Debbie. I'd jump in saying, I don't know if it's a national publication, a state-based publication. If it's a national publication, highlight that the open enrollment period is shortened in the federal marketplace to only 6 weeks, and you only have until December 15th to get covered for 2018. Obviously, if you are a cancer patient, having coverage is fundamentally important. And if people think they have 3 months, they might not act. And in the past, it always was 3 months. It's down to 6 weeks now. So I think the most important thing for people is to recognize that they need to enroll by December 15th. Even in a state like D.C., where we have all the way through January 31st that we have open enrollment, you would still need to enroll by December 15th if you want January 1 coverage. So, just making sure that people don't miss deadlines. And then if there's someone who's already covered through a health insurance exchange and they're being auto-renewed, check that policy and shop and compare.
The other thing I would add to that, I think it's real important. We work pretty close with the cancer centers around here, and I think we want to make sure that when we're talking to consumers, they need to know. It's real important that they know what plans that their providers are taking. If they plan to stick with a particular provider or a particular center that they want to be able to use, they need to make sure that when they're enrolling in a plan, they're getting a plan that will allow them to go to the provider that they want. For example, here we see a lot of patients that prefer to have access to Moffitt Cancer Center. Well, not all the plans cover Moffitt Cancer Center, so they need to be able to go through the plans and find out which plans cover that center, that healthcare provider. So I think those are really important, is understanding, again, which plans are going to provide the coverage they need, both for services and providers.
And for medications, I would just add on there, Jodi, and I'll tell you, on DC HealthLink, we actually have we have what we call our DC HealthLink Plan Match tool, and it lets you put in your providers by name, your doctors. It's only doctors so far, but you can plug in your doctors, and it tells you which plans your doctor takes. And you can also plug in your formulary. You can also plug in your prescription drugs, and it will tell you how they're covered on the plan. Those are really important things for people to do.
And the federal marketplace has that tool as well.
Great, thank you. We have another question from Chelsea, and I think this question really illustrates the confusion that the repeal efforts have caused around patient protections. So her question is, are pre-existing conditions going to become part of what is looked at or considered during enrollment?
No, it is not. We do not ask anything about pre-existing conditions. The only thing that's relevant if the consumer feels like it's important is, again, going back to picking a plan that will cover the providers and medications that an individual needs, but there is nothing on the application that will ask you if you have a pre-existing condition. So that is not factored into determining premiums or eligibility.
But you actually raise a really good point and an appropriate concern. That what Jodi said is absolutely right. Under the Affordable Care Act, pre-existing conditions exclusions are not permitted. However, the President did put out an executive order in October that called on the ability. It is an executive order that was discussed as allowing people to purchase health insurance across state lines. The other thing that policy would do if it gets enacted, and again, it's just an executive order, so it doesn't, at this point, it hasn't changed anything, but if they were to move forward and implement it, their second one is to allow what are called limited duration health plans to exist for a whole year. A limited duration health plan is not minimum essential coverage. It does not have to meet the ACA requirements on pre-existing conditions, on coverage, on anything. They are often, they're often called mini-med policies or short-term policies that people get just if they're in a waiting period at work. The Obama administration limited these plans to no more than 3 months because there's so much confusion in the marketplace on the outside when brokers try to sell these policies. People think they're getting coverage that will work for them, and in fact, it covers almost nothing. So if that executive order moves forward, that's really problematic because we all know that one of the number one drivers in health insurance from a consumer perspective is price. And because those policies cover very little, they're cheap, and people can get hoodwinked into buying them thinking they're getting ACA coverage, and they're not. So that's just something to continue to look out for. It would be a real problem.
Thank you. I have a question that is, you've talked about how if you're getting the tax credit, if you qualify for the subsidy, then you're going to be protected from these high premium increases. But the people who have income over 400% of poverty are not going to be protected, and they're really going to be hurting with the high premiums. What is your advice for them? I know that Debbie, you said in DC your only choice is really to buy through the exchanges, but I've heard that in some states you may be better going off the exchange to try to find plans if you're in that tax or in that income bracket where you're not going to get a subsidy. What is the best advice for people who don't qualify for subsidies?
I would say in Florida, that's probably, we're in the situation where I've spent a lot of time enrolling people in full pay plans in the past because there were some, really good plans that were available, but because of these premium increases, we're encouraging people to look at the off-marketplace plans, whether they go directly to, a Florida Blue place or another agent or broker, just to see if there are any quality options. I don't know what the off-market plans look like at this point, but we know the premiums have gone up a lot.
Yeah, and I would just add, I mean, there is a real downside to buying a non-exchange policy, and that's this. None of us know if our incomes are going to remain what they are through the course of the year. And when you have coverage that you purchase through a marketplace, through an exchange, then, you know, even if you're not getting the advanced premium tax credits, on your federal taxes, you can apply for the premium to get the money back, and you get it on your taxes. So if your income were to change during the year and you had an off-exchange policy, off-exchange policies don't qualify at all for getting that money on your federal taxes. So you are potentially giving up a real financial protection. But if the premiums are vastly different, you know, people need to make that informed choice. In D.C., 97% of the policies we sell through DC HealthLink are full pay policies because our Medicaid program goes so high, it goes all the way to 215% of poverty, that, you know, there just aren't that many people who are qualifying for advanced premium tax credits. It's just people between 215 and 400% of poverty. So we only have about 1,000 people that get the advanced premium tax credits, and and only about 300 who gets cost sharing reductions. So, I mean, in another way, we were very lucky. The cost sharing reduction debacle across the country is not impacting us at all because it's such a small value in D.C. So we don't have the on-exchange, off-exchange dilemma that is elsewhere in the country. But my advice would not be to go solely to a broker, frankly, and ask the broker what to do. I would go onto your state marketplace. I would figure out what options are there, and then I'd talk to a broker and see what they say to you and do that comparison yourself.
Okay, thank you very much. We are really out of time, but I'm just going to combine two people's questions into one, which is basically how accurate is the information about what providers are on what plans? I know you said you have it on the federal exchange and on the DC exchange, but I think, you know,
it's a problem. It's a huge problem. The data is as accurate as it is updated. And so the updates, you know, if you talk to the health insurers, they will blame the providers. If you talk to the providers, they will blame the health insurers. It is a serious problem. We've taken steps in D.C. to try to up the standards for what you're required to do as part of being certified as a health plan to be on DC HealthLink. And our insurance commissioner is upping those standards even more now because of continued public outcry over the weakness of some of this information. It's a legit problem. Okay. Jodi, I don't know if you feel the same way in Florida.
Yeah, it's one of the things that we do a lot of and encourage our consumers to do a lot of is verify with the provider. I mean, there's no harm in double checking because we've certainly seen where some of those networks are not accurate. So I think in the best interest of the consumer, you know, we encourage them to reach out or help them call the providers to check to make sure that information is true.
Well, we are out of time. It's 2 o'clock. So thank you both so much for this. This was incredibly helpful, and I know I learned some things I didn't know. You know, we're focused on the legislative piece of it, and you guys are the ones actually implementing it and helping people get enrolled. So this has been incredibly helpful to us. And I think, you know, if we have additional questions, we may follow up with you both individually. But I just want to thank you very much for joining us, for sharing information, and thank you to all of you for joining this webcast today. And we will get this up on our website as soon as we can get the audio. So thank you very much, and have a wonderful day.
Thank you.
Thank you.
And with that, we will conclude today's webcast. Thank you for your participation in today's webcast. Today's program is copyright 2017 by the National Coalition for Cancer Survivorship with all rights reserved. This concludes today's program. Thank you. You may now disconnect.